Um, am I audible, Rajani?
Yes, ma'am. A little more louder would be good.
Yeah. Thank you everyone for joining in for today's session. This is kind of much awaited session for us personally because we have three eminent faculty dealing with three different areas of palliative care in ICU. So we have divided these topics into how to incorporate palliative care in ICU, what are the challenges and solutions, which will be taken by Dr. Rajani. Dr. Rajani was involved in the program since the beginning. Many of you might have seen her during the program. She is a pulmonologist working in Bangalore, and she has done her internal medicine and fellowship in pulmonary disease from New York. And she has her interest. I would like to highlight that she is very much interested in palliative care, incorporating palliative care and end of life care in ICU and the pulmonology settings because of her experience in dealing with illnesses towards end of life care. And second topic, we have withholding, withdrawing treatments. And we have, I think we cannot find any other faculty for this other than Dr. Raj K. Mani. He is a pulmonologist, very well-known pulmonologist. Many of you might know him from, he's a group CEO and chairman, critical care, pulmonology and sleep medicine. And he is a former president of Indian Society of Critical Care Medicine. And very importantly, he was a part of the document which has compiled the guidelines of end-of-life care and palliative care. So we know that there is no other person who can talk about this particular topic. And third, we have Dr. Dhvani. Dr. Dhvani will be talking about medical legal issues in end-of-life care in India. Again, Dr. Dhvani is a co-founder of the VT Center for Legal Policy. And she has represented in the Supreme Court of India in Common Courts versus Union of India. And she was a part of the expert committee of Indian Council of Medical Research. Do not attempt resuscitation. So again, there is no one else who can talk from her own experience and her journey through the medical legal issues with end of life care in India. So I'm really looking forward for a wonderful session with the three eminent faculty in this field. So welcome you all for the wonderful session today. Well, I welcome all the faculty, all the three faculty members for today's session. I think we're starting with Dr. Rajani. Rajalakshmi, shall we?
Good evening and welcome to this session of the Essentials of Palliative Medicine for Pulmonologists. Today's session, we will be discussing about palliative care in ICU, and we'll divide the section into one broad discussion on different aspects of palliative care in ICU, addressing some of the challenges and the ethical dilemmas that we face. We'll look at specifics about withdrawal and withholding life-sustaining treatment, and we will also look at the medico-legal perspectives. So diving right into issues regarding palliative care in ICU, let's start with addressing what has been a common misconception for a long time, that palliative care is about end-of-life care. We've discussed over the last several weeks about how palliative care begins at the time of diagnosis. Most certainly in chronic respiratory diseases, we've now realized the value of a palliative care approach from the early part of diagnosis itself. Coming to end of life care, it's a sad state of affairs where patients with chronic respiratory disease, unfortunately, a lot of them end up spending the end of their life in hospitals or in ICUs. We hope that this will change with a greater incorporation of palliative care in the early parts of the disease. But until such a time as this becomes accepted practice and a standard of care, we must still look at what can we do to improve the quality of end of life care. And this means that palliative care must be incorporated into ICU care as well. If we look at what the official ATA statement was in 2008, it clearly says that palliative care, the concept of palliative care has shifted from a temporarily disconnected, disjointed part of medicine which starts after all curative and respiratory care has stopped or is no longer effective, to an integrated model Where palliative care begins, along with curative and restorative care, the patient's disease trajectory may go up and down, and the component of palliative care will go up and down depending on what is needed more by the patient. Palliative care also continues beyond the death of the patient to the period of bereavement. When we look at the bottom right hand corner of the screen here, and this looks specifically at curative, restorative care, and palliative care after admission to the ICU. Here too, we see the model of care that has been suggested is one where palliative care is incorporated from the time of admission to ICU, intensifies if the patient's prognosis worsens and condition becomes more critical, and continues after the death to bereavement, providing support not just to the family or caregivers of the patient, but also to the healthcare staff who may be distressed by the conditions surrounding the death of a patient in an ICU. What are the guidelines that have been issued by professional bodies? There are multiple professional bodies which have made statements over the last decade and more, with recommendations for end of life care in the intensive care unit, as consensus statement issued by the American College of Critical Care Medicine. There was a consensus, a worldwide consensus on end of life care practices for patients in intensive care units. And this incorporated suggestions from critical care physicians from around the world, including ICU physicians from India, for what would be the best practices that would be advocated by professional bodies across the world. And this includes aspects of informed consent, shared decision making, assignment of surrogate decision makers, um, decisions around requests for inappropriate treatment. What is the meaning of inappropriate or non beneficial treatment versus futility, a controversial term? And in India, closer to home, we have an integrated care plan for the dying, a joint position statement of the Indian Society of Critical Care Medicine, along with the Indian Association of Palliative Care, which came out in 2014. More recently, the Indian Council of Medical Research guidelines on do not attempt resuscitation were issued in 2020. This is a narrower scope of practice document compared to the end of life care policy statement issued by the ISCCM and IAPC. However, it does add a lot of weightage to current practice because of the misconceptions surrounding the legality of what is allowed, not allowed in India, what is supported and not supported by professional bodies and the law in India. These will be aspects that we will discuss later on this evening as well. So from 2008, there is a consensus that end of life care is emerging as a comprehensive area of expertise that one needs to pay attention to, and that it demands the same high level of knowledge and competence as other areas of ICU practice. So if we think of ourselves as respiratory and critical care physicians, we would want ourselves to be well versed with all aspects of ICU care, and that would involve management of ARDS, management of type 2 respiratory failure. And I can't imagine that if something was thought to be an essential competency for us as ICU physicians, that we would not pay attention to it over 14 years. So if a guideline was laid down in 2008, how and why is it that it is not being implemented universally, uniformly as standard of care in 2022? There is clearly a no-do gap. And there are many reasons for late referral to palliative care or incorporation of palliative care practices. Studies have shown that on ICU admission, 97% of patients who had any kind of cancer warranted the palliative care evaluation. However, the palliative care evaluation happened for a median at 0 days before death, which means that the palliative care consult was requested practically on the day the patient died. Chronic lung disease patients we know fare worse than lung cancer patients. The quality of death and dying in ILD patients is worse than that in lung cancer patients. And that is something that we hope to change in the future by encouraging more and more incorporation of palliative care principles into routine pulmonology practice. When we look at the attitudes of intensive care unit physicians, most of them will agree that palliative care is essential to their practice, is an important aspect of their practice. But younger ICU physicians, they note, find it easier to refer to palliative care for the difficult conversations. And we've had sessions already on communications about difficult conversations. I would like to think of difficult conversations and communications about end of life care as a difficult procedure that we gain mastery over. So, just as we gain mastery over a lumbar puncture or a bronchoscopy, an intubation, or a central line placement, this is a procedure that we can gain competence on with greater practice. It's a sad situation that even when palliative care consults are called, often they are not carried out, the suggestions are not carried out because of phobias and biases that physicians may carry or patients themselves may carry. So opioids may or may not be given in the adequate doses because of bias on both sides. Another unfortunate occurrence that happens in India is the practice of terminal discharges, which is when a patient has a bad prognosis and may not make it. The family is told, especially if they are in a financially weak situation, that no further benefit can be offered to the patient. And the patient is discharged very often with an endotracheal tube in place, which is removed in transit, and the patient is in distress at the end of life. The family caregiver as well as the patient go through a terrible time in this process. It's unthinkable that something like this should happen without palliative care for the alleviation of symptoms at the end of life, and it's a highly undignified way of demise. What are the barriers to implementing palliative care in ICUs? It's a demanding and complex environment, no doubt, the intensive care unit, but multiple barriers have been identified in studies. There's a lack of preparation. People think of it as a nice to have. It's a nice add on, it's a luxury, however, not a necessity. There are sometimes healthcare system related barriers where palliative care services may not be available within the system. There's a lack of cultural acceptance of palliative care. In certain cultures, accepting that um, uh, the patient is going to die may be difficult for some patients, or a doctor offering palliative care is considered a dereliction of taking away hope from the patient. There's a lack of knowledge and training from healthcare workers as well. Patients in ICUs experience a myriad of symptoms, and principal amongst these are pain, dyspnea, and thirst. A majority of patients refer to pain that no matter what is the reason for hospitalization, whether it is for cardiac surgery or a neurological issue or a respiratory issue or a multi-organ failure and sepsis, they all experience pain. Majority of them experience pain. Breathlessness is experienced by a large number of patients in ICUs. In fact, even patients on mechanical ventilation experience breathlessness. So this is their memory after extubation, that they felt breathless even on the ventilator, which means that we're not doing a good job of offering them enough opioids and benzodiazepines to alleviate the sensation of breathlessness. Another symptom that troubles patients a lot is thirst. A whopping 71% of patients say that they experience thirst, parched, dry mouth, and oral membranes. Xerostomia is a very troublesome symptom. Patients experience agitation, delirium. They're extremely anxious. There's sleep disturbance because there's lights and sounds in the ICU at all times. They may not be able to communicate, either because of a physical problem with communication or because of tubes in their mouth or a complete lack of energy. And any communication aids that we can provide them, pictorial things, things they can point to, would be very helpful. Caregivers experience a lot of distress, seeing their loved one in a lot of pain and suffering. So there's ways of alleviating these distressing symptoms that patients and caregivers go through, that if only we think of some solutions for them, some simple communication aids involving the family in care, asking the family to wipe the mouth, place ice chips in the mouth, that will allow for a greater sense of connection for the patient as well as for the family. There are some special situations that we must be mindful of. For patients with chronic respiratory disease, we know that that might be anticipated with progression, and it's important to have advanced care plans in place, have an emergency plan in place for what to do in case of an emergency. However, there are some respiratory conditions where you might have sudden advanced illness. And this could be something like a situation where we know that a patient has had hemoptysis and may have another occurrence. So it's important to have a plan in place for patients who have chronic progressive illness or those who might face a sudden emergency as well. The use of non-invasive ventilation and high-flow nasal cannula has been advocated for relief of symptoms in a certain group of patients. NIV is more useful in patients with COPD. High-flow nasal cannula has been shown to be useful in ILD for relief of breathlessness. It must be kept in mind that these are not enough on their own alone to relieve breathlessness. So this must be done with judicious use of opioids in order to relieve the breathlessness. And it must be done according to what is needed for the patient. If it seems like the patient's breathlessness is being alleviated over time with the use of the opioids, one may be able to reduce the usage of NIV and high flow nasal cannula towards the very end of life in the phase of active dying. The four pillars on which we base most of our clinical decision making are these pillars of medical ethics: beneficence, which is looking at what is good for the patient's best interest; non-maleficence, which is to do no harm; autonomy, which is that the patient has the right to make all decisions regarding their healthcare. If the patient lacks decision making capacity, then a surrogate or a proxy who's a next of kin or a designated surrogate by the patient or the family would be the one who would make decision. And justice, which is the use of resources appropriately, especially in situations like the pandemic that we have faced. An important point to keep in mind with autonomy is that it applies not just to patient but also to us as clinicians. We are not bound to provide non-beneficial treatment. We are not bound to provide any and every care that is requested of us by a patient if that is not beneficial, unethical, or inappropriate. In order for us to be able to balance these four pillars to provide a stable clinical care pathway for the patient, sometimes we need to find out when there is a conflict between these four pillars. Often the conflict comes up with beneficence and autonomy. And this is the part we must learn to sort out within our own clinical decision making abilities. So, for that, one needs a good handle on prognostication to be able to question what is the good that will come for a patient with a certain course of action and what may be the harm that may come, and what would be the options if we do not pursue a certain course of action. While communicating with the patients, we have to balance truth telling with hope. And it's important always to remember the principle of shared or supported decision making. Some patients, such as those who have intellectual disabilities or physical disabilities, are often overlooked and don't get the same rights and agency as other patients in making their decisions. However, all they need is a little bit more information and a little bit more time. So it's important that we respect the autonomy and the rights of a patient at all times if the patient is conscious and has decision-making ability. It's important also to address the doctrine of double effect. When we look at the use of opioids or benzodiazepines to relieve dyspnea, some clinicians worry about the fact that it may hasten death in a patient. If a patient has a very poor prognosis and the goal of care is to provide as much comfort as is possible, then the doctrine of double effect applies, as our primary goal being to relieve the symptom which is distressing the patient most, which is pain and dyspnea. And if that is the primary goal of care, and we accept the possible side effects of a hastening of the active dying process, as long as we document, communicate adequately with compassion with patients and their caregivers, and respect the autonomy of the patient's decisions in their best interest, we will not be straying away from these ethical principles. It's important that we look at this as something that we habituate ourselves with. So with every clinical decision that we make in the ICU, we look at it in terms of knowledge that we are building on with every procedure, with every patient who goes through similar situations. Then over time, it becomes an automatic part of our clinical practice, just as we do all our other protocols as second nature to us. The ethics of palliative care in ICU has been debated a lot, especially in the Indian context, saying that, oh, this works in the Western context, but not so much in the Indian context. However, in the recent years, we have standards that have been set for us. We have consensus statements that have come in, which will help hospital administrators as well as clinicians to practice ethical, humane, patient-centered, family-centered palliative care in the ICU. And I would highly recommend reading these 3 documents, which I'm happy to share. I will share it with the Pallium team so that it can be shared with all of you, because this will help us to set certain procedures in place in our own institutions to facilitate better palliative care in ICU. We can look at various models of care. An integrated model is where palliative care team is part of the ICU team or rounds regularly with the ICU team. A consultative model would be where the primary palliative care is done by the ICU team for every patient. And we call on specialist palliative care only for those who have very high palliative care needs. And of course, with the advent of telehealth, we know that we have expanded access to specialist palliative care consults. So I see no reason why the future of critical care in India should not involve palliative care being incorporated into practice for all our patients, especially those who have chronic respiratory disease. How do we measure the success of our treatment in ICUs? It's by asking the right question. It isn't about what is the matter with you. It's more about what matters to you. And I'd like to share a small story about this patient, which was shared by an intensive care physician in the US. This gentleman was hospitalized and intubated for type 2 chronic respiratory failure. It was understood that he was failing multiple attempts at extubation, and he expressed his wish that he did not want to die like this. He wanted to be extubated. He wanted withdrawal of life-sustaining treatment. He wanted a cold beer. He wanted his wife at the bedside holding his hand. And this is what they achieved with the judicious use of opioids, with benzodiazepines. And there you have this gentleman with a cold beer in his hand, his wife holding his hand, because what mattered to him was that he was able to hold her hand before he breathed his last. So it's by asking the right question, what matters to the patient, not about treating a disease as what is the matter with you. In the end, we learn from the stories of our patients and their journeys in life and in death. And if we keep the stories and the wishes of our patients front and center in our decision making, even at the end of life in ICUs, then we will be able to incorporate a palliative care focus in our approach to the care of patients at the end of life in ICUs as well. Thank you very much for your close attention. And I'm looking forward to Dr. Mani's further exploration. He's one of the chief architects of many of the guiding documents and consensus statements that I mentioned in my talk, and also one of the leading lights who's guiding the movement towards humane and ethical end-of-life care in India. We look forward to hearing from him about the more complex discussions about withdrawal and withholding life-sustaining treatment. Thank you.
Thank you, Dr. Rajani, for starting the session. Wonderful points, wonderfully delivered. Dr. Raj, thank you so much for being a part of this wonderful program. Really looking forward to hearing from you. Over to you.
Yeah, thank you so much, Rajani, for the wonderful talk, which spanned quite a wide range of subjects, relating to palliative care in the ICU. And I thank you very much for this platform to meet you all with a subject which is close to my heart, and it's so relevant to intensive care practice. As you know, most of those who can afford, they tend to come to hospital to die or into the ICU, no matter the age, from infancy to the very aged, no matter the stage of illness. So that is the culture today. Those who can't afford, anyway, they are neglected, those who can, or those who somehow manage to put together some money, they all come to die in the ICU in not very dignified state. So there was a recent very moving poem published in the Intensive Care Medicine, by a neonatologist, as it were, spoken by a newborn, okay? A premature baby I was born premature, 4 months early. You intubated me, put me on a ventilator because you could. My lungs were weak. You gave me surfactant and waited for them to grow because you could. So the infant, as it were, speaks about getting a shunt put in the brain and then having a tracheostomy and continuing on a ventilator in a difficult status, eventually not, the doctors not achieving their goal. And so that is the number of interventions that an infant goes through, even when it is very clear at some point that these interventions are futile. Why do we keep doing this? Why is there this culture? Because we haven't distinguished between the two words, you could and you must. Okay? Because you have advances in technology, because you have interventions, because you have a lot of fancy technology, does not necessarily mean that you must apply those interventions indiscriminately and unwisely. So in the modern times, death has become a paradox. Since the advent of intensive care, since the advent of all these life-prolonging interventions and life-supporting interventions, dying has become complicated. Now that we have a term called brain death and somatic continuation of life. Most who can afford die in the ICU, particularly in India, where most of the modern medical facilities, advanced facilities are in the private sector, this has caused huge amount of iatrogenic misery. Medicalized, lonely and impersonal deaths have become the norm now. And they are often burdensome, painful and expensive. And those who cannot afford have no access to life-saving. They die without even the necessary interventions. Everybody anyway dies without adequate palliative care. This is why the twain must meet, the intensive care and palliative care, not just for the dying, as Rajani said, right from the start to finish of intensive care. In fact, right from the start of any diagnosis, as she said, much before the question of intensive care comes about. So what is the context of withdrawal and withholding? Disproportionate medical interventions are rife in the ICU. You can see, whatever be the stage of the illness, this is the way, number of machines surrounding the patient, no human being, more machines. So Ruth Pyers et al. From Belgium did a survey of European ICUs and found that about 1/5 of all ICU interventions are disproportionate. That means more than what is needed, being futile or non-beneficial. And this could be an underestimate for us in our context. Why do we end up doing all this? What are the barriers or what are the facilitators of a good end-of-life care? So you can see there is the ecosystem, and which is 3-layered, and then there are barriers and facilitators, in those 3 concentric layers. Firstly, the national culture of how we deal with the dying, what is our attitude towards palliative care? What is our attitude towards healthcare in general? What is the national policy? Now, in our country, there is inclusion of palliative care in the national policy at long last. Then there is the institutional culture, institutional policy. Most institutional culture is just to talk about curative care. Do more and more. Never stop to consider whether I'm doing too much. That's not the culture. And the administrators have the culture of stopping you when you want to do a humane care by reducing the burdens. At the clinicians and family level also, there's a lot of personal problem, in the sense that we have not confronted death ourselves. So we are unable to help other people confront death. And similarly, the family is wary of discussing death. They think it's an ill omen or an upshakun to talk about death, even if it is staring at you in the face. So, and there are cultural, religious, and personal factors in this dynamic. What's happening in India is that we are all dying badly. Now, the quality of death index declares us to be among the poorest ratings in both 2015 and 2022. We have an undeveloped system of caring, with a notable exception of Kerala, and under the pioneership of Dr. M.R. Rajagopal, that there is a community palliative care that has evolved. But however, I do not know what is the culture of palliative care in the ICUs in Kerala. I'm not having much information or data on that. Palliative care has come to stay in our country, but it's still evolving. It's got a long way to go. And the national policy is quite silent on death and dying. It talks about palliative care in the community, palliative care for cancer, but doesn't discuss death and dying and the quality and the needs of the dying. So withdrawal and withholding, what do they mean really? I mean, so in a nutshell, withdrawal is discontinuation of any life support modality when it is judged to be non-beneficial, in accordance with the informed choice of the patient or surrogate. Okay, there is the physician prognostication and physician understanding of the case, together with the patient choice, either expressed directly or indirectly through surrogates. And withholding is not initiating any intervention at all. We stop short before and take a considered decision not to start at all. So withdrawal is interruption at any stage. It could be not just ventilation. It could be vasopressors, it could be antibiotics, it could be withdrawal of hemodialysis, withdrawal of ECMO. All right. So any of these life supporting modalities which have proven clearly that they are not getting us anywhere. So there's very little published literature on the practice of end-of-life care, with foregoing of life support in India. The first one was in 2005 by Kapadia et al., a 4-center retrospective culled from the SAPS-3 database, published in Critical Care Medicine. In 2009, it was from my group, a single-center retrospective published in the Intensive Care Medicine. And Tata Memorial Hospital Experience, these are in the form of abstracts and personal communication. INDICAPS 1 and 2, this is a national survey, I mean, it's a ISCCM sponsored and multi-center survey of ICUs in India in 2012 and 2021. These gave us data on how end-of-life care is practiced across the ICUs, very poorly, I must say. So Asian survey in 2015 about physician attitudes in India. CMC, it's about the whole of Southeast Asia, but culled from that are data from Indian physicians. CMC Vellore has a publication of a retrospective audit of the end-of-life care practices in the ICU. So formal withdrawal withholding have been few and far between in India all these years. And INDICAP 1 and 2 reveal that 1/3 of the deaths are via the LAMA or DAMA, left against medical advice designation, or discharge against medical advice. So 124 ICUs, 4,000 odd patients in both 2010, 2011, and between 2019 and 2020, or about, 10 years apart. So they were point prevalence studies. 80% of these were the private sector. So what they found was 1/3 of all these deaths were terminal discharges, not formal, but through the LAMA designation, that there is no proper, structured, or organized palliative care delivered to these patients. We are just wash our hands off. That's it. So this has only increased since the first publication, INDICAP 1. it is now handicap 2, 7.6% versus 4.5% of overall admissions, which is staggering. So in the rest, of course, in the 70%, there was no form of limitation at all. They were all full support cases until death. So it's a pernicious practice like Pontius Pilate. We wash off our responsibility to address the moral and the humanitarian considerations in those decisions, and there is no attempt to address the issues of formal foregoing of life support or dignity in death. These are only crude attempts at escaping legal liability. That's it. So the patient and family are left to their fate, really, to face death without any support of palliative care. So as a widely publicized case is shown, which was publicized a few years ago in that Adya Singh versus Fortis Hospital, and the Lama is no protection against litigation. Okay, it doesn't absolve us of our obligations. Rajani has gone through this. A brief look at ethics and professionalism. Autonomy is the patient's right. Beneficence, non-maleficence, and justice and equity are our obligations, physician obligations. So we are also obliged to practice evidence-based medicine, which includes setting of goals of care and then treatments in concordance with the goals of care. And it also calls for improvement in communication, training ourselves in good communication, which involves truth-telling, evincing compassion, and also being transparent. Best interest of the patients is the only interest. This is also our ethics, not best interest of ourselves, not the best interest of the place we are working in alone. The most important priority is best interest of the patient, and it is extremely important for us to aim at palliation, mitigation of suffering at all times, and particularly so towards the end of life, when there is no component of curative attempts. In the world, foregoing of life support has been easier and easier over the last 3 decades. So there were precedents and legal case laws in the US since the 70s. There is legislation across the world, over 17, 20 countries, and these are continuously evolving. There are copious data, the surveys of foregoing life support decisions in the ICU across the world. It is very common now. 70 to 90% of deaths in the ICUs in the US and in Europe are through some form of treatment limitation. In fact, the respect to autonomy has been taken to its extreme manifestation in the form of medical assistance in death, which is like physician assisted death or active euthanasia, and is increasingly becoming acceptable in many countries and many states of the US. So Indian data, of course, in all these areas is quite sparse. You can see this is a meta-analysis published in 2015 in ICU. Which shows us the proportion of withdrawal and withholding in various countries. So withdrawal is the black bar and withholding is the gray bar. So you can see withdrawal and withholding both being very frequent. Withdrawal is in fact a higher proportion in most advanced countries. Not in our country, because we somehow are very shy of withdrawal. We may get ourselves to accept withholding, but not withdrawal. But this is not the case in the rest of the world. In the rest of the world, except Israel, where due to religious reasons, they do not accept withdrawal as is practiced elsewhere. They have their own mechanism. They cannot stop an ongoing life support, so they add an interrupter in the ventilatory circuit and then do the withdrawal. So there was the large Ethicus study, a large survey of end-of-life care practices in Europe, which was published in 1999 first. I mean, 2000 actually, 1999 to 2000. And 15 years later, again in Ethicus 2, 2015, 2016, you see the prevalence of end-of-life care decisions and the confidence has increased greatly. It is now 90% of deaths versus 68% in the first study. So fewer and fewer people are getting full support going towards their death, in these ICUs. Closer home in South Korea, recently, this was a publication where there was a promulgation and implementation of the well-dying law. Okay, an end-of-life care law was framed and published in 2018, and since that time, there's been improvement in the quality of death in their ICUs. So this is measured by the QODD, the quality of death and dying, and there are 20 points in that questionnaire of quality of death and dying. In most of these counts, 20 counts, there was improvement, as you can see, in the orange bars as compared to blue bars, comparing the before and after the well-dying law. So when the ecosystem, when the culture of the country, or thinking in the country and legislation, all this takes place and awareness improves, the quality of dying also correspondingly shows improvement. So we, in our own small way, have attempted to address the issue of quality of dying in the ISACM initially, Indian Society of Critical Care Medicine in 2005, was the first publication on end-of-life care. And subsequently, it was revised in 2012. And then in 2014, the Indian Association of Palliative Care and Indian Society of Critical Care Medicine came together in the care of the dying. And an integrated care plan of the dying was published. Please look at it. It's there in Google search, and you will find a comprehensive review and guideline running into 20 odd pages. So more recently, after the Common Cause versus the Union of India judgment in 2018, which for the first time clearly constitutionally allowed foregoing of life support in India and also the right to execute an advance will, we published along with the ELICIT, that is end-of-life care in India task force, which includes members from 3 different societies, ISCCM, IAPC, and Indian Association, Indian Academy of Neurology, IA. So the 3 societies are represented in this group of ELICIT, and they, along with FICCI, Federation of the Chambers of Commerce and Industry of India, we formed these steps in the shared decision making for withdrawal and withholding. I'll briefly take you through them. Firstly, we must accurately identify situations where the trajectory of the illness is no longer found to be curable. Okay, reached a stage of no return. Now, this may take a while to become very clear. It may not always be very clear at the outset. In fact, most of the cases who are very sick in the ICU are in the gray zone. We're not yet sure whether they are still, there's room for a curative approach, or have they entered the zone in which, we can make a clear switch to palliative care. So this may take time, an iterative process with frequent, putting heads together within the team. Then you identify those situations when there is clarity. When there is consensus, you take it to the family. Okay, as a group, as a team, you take it to the family. Put the probabilistic prognosis on the table, with as much honesty and accuracy as is possible within the uncertainties in medicine. And then you not only provide the family with existing options for mitigating the illness or prolonging life, but also share with them the palliative care option, comfort care option, which focuses more on patient values, what as expressed by the family, and also on the possibility that excess burdens may be put on the patient, and the goal is to avoid them. So if the patient is competent enough to engage in a shared decision making, and he or she doesn't want it to be relegated to the family, then deal with the patient as compassionately as possible, directly with honesty. And then if the patient is not competent, that is in terms of comprehension and ability to participate, and then if then advance will is available, then integrate that into your decision. If it's not available, now cogitate with the family, with repeated family conferences, which have to be properly structured and have the content that is now being increasingly being improved upon in guidelines for and training for communication. Integrate all those values, and then take a combined decision, so-called shared decision making, which combines the autonomy of the patient as well as the obligation, beneficence and non-maleficence and justice on the part of the physician. And this is as close as you can get to the ethical decision making. And then resolve this issue of making a decision. Once withdrawal-withholding decision is made, we must implement it, integrating all the palliative care principles. If it's a withdrawal, then you have to have anticipatory analgesia and sedation, and with proper titration and proper endpoints being defined and achieved in doing so. So as Rajani showed, there were many other documents which can be very useful in implementing these decisions. Blue Maple, for example, has all the forms and the formalities required to take these decisions forward. And then ICMR has published the document on do not attempt resuscitation. You will find the necessary practical considerations and practical guidance in making a DNAR decision. Now, DNAR is the simplest end-of-life care decision, which is a withholding decision. DNAR is not equal to euthanasia by any stretch of imagination, nor is it equal to withdrawal or withholding. DNAR is just that. Defining the code status of CPR, whether the patient has a realistic chance with CPR or has no chance with CPR. If there's no chance with CPR, then we would be doing more harm than good by attempting CPR. So this is the principle on which is based a DNAR guidance document. And more recently, the All India Institute has come up with its institutional guideline. This is also a very practical document, and this is yet to be published, but it is available on the net. There is this vexed question of the law, which we keep coming back to. Dhvani will deal with it. Dr. Dhvani Mehta, our legal expert, who has worked with us so closely and wonderfully in the last 4 to 5 years with Elicit, and worked with us in all these documents that we have developed. So she will clarify the legal nuances, but suffice it to say that it's constitutionally valid to do withdrawal withholding decisions. And in fact, we have a duty to uphold autonomy and privacy and the best interests of the patient. It's a duty, in fact. But the procedure prescribed by the Supreme Court actually hampers the practice, so that we are working on that, how to simplify the court procedure. We have appealed to the Supreme Court. So this is, once death takes place, it's extremely important to have the death rituals. We all know We all do that. And in our country, there are so many religions, each one has a very unique death ritual, and that is part of the dignity of dying. Now, this is a personage, a religious personage, who was said to be 102 years old. He was admitted with me with very advanced ILD. He had a large number of followers, hundreds of them being doctors. So the followers were the surrogates. The followers wanted everything done up to a point, but we kept talking to them. So they wanted us to go ahead with intubation. On one condition, we agreed that it will be a time-limited trial, TMT. It can't be forever. We can't do that to our patient. So a time-limited trial of 48 hours was given. When things were not going right, then there was a collective decision to take him back to the ashram where he was extubated. That is, a withdrawal decision was implemented with the due palliative care processes. And then immediately, as his station, spiritual station required, he was put in this posture, which could be possible because before the rigor mortis set in, could be done in the lotus posture, and a very dignified process of death ritual could be followed to the great satisfaction of his thronging followers. So to conclude, I must say the withdrawal, withholding, and DNR decision making is essential for avoiding non-beneficial treatment burdens in the ICU and in the community. These decisions are based on ethics, patient rights, and professional integrity. The accepted model is the shared decision model, which I elaborated a bit, and the ecosystem of culture, acceptability of death, social, societal awareness of the needs of the dying, professional beliefs, biases, training, and fear of the law and its implications, national policies, etc., impact on the ease of decision making, establishing establishing the constitutional validity of foregoing of life support and advanced medical directives have not yet changed the practice on the ground, mainly because of the restrictive procedure and lack of the drive to reform. So the ball is in our court. We have to sustain this drive to reform and let this awareness and concept and humanity percolate everywhere in the society. I will end by showing you that there is a lot more in medical practice than prescribing a medicine, doing a procedure. It is actually connecting with people, actually touching hearts. So after a very effective end-of-life decision was done to a mother of a famous classical musician, we received this very kind note, and this is preserved in my archives. So she's written that, in meaning to write this, I found it impossible to find the right words to thank you for the care and the concern that you so generously provided. So this is what it is. We should be known for our caring. We should be as well known for the skills of the heart as skills of the mind, hand. And so thank you very much for your patience. Thank you all.
Thank you so much, Dr. Raj, and thank you so much for sharing this note and how important it is to hear these words from patients, caregivers. And it's all about the care and the concern. It's not about the medicines or the expertise that you gave in an ICU setting. That conveys a lot. Thank you so much, Dr. Raj, as always, for a wonderful session. And now we'll hear from Dr. Dhvani about the medical legal aspects of palliative care. Over to you, Dr. Dhvani.
Thank you very much. It's a real pleasure for me to be speaking to all of you this evening. I've had the privilege of working with Dr. Raj, Dr. Rajani, Dr. Rajam, such wonderful, compassionate, fearless doctors. They have really changed the way in which I think about the law as well. And I'm really grateful to them for that. And so I'm very happy to be sharing those views with all of you today. And I hope that they can enable you to practice medicine in an ethical and responsible way, just as Dr. Mani and Dr. Rajani have described. I think they've already covered, the basic, well, not the basic, they've covered a very comprehensive, they provided a very comprehensive overview of palliative care, and Dr. Mani especially has touched on the fundamentals of the law as well. So I'll keep my talk fairly brief. And I'd be very happy to address any questions that you might have in the Q&A session. So I thought what I would do is divide my talk into describing the normative foundations of the law as it currently stands as far as end-of-life care in India is concerned, then tell you about what the procedure prescribes and how the law is expected to be practiced, and then explain what is it that should be done practically for both for patients, caregivers, healthcare professionals to overcome the challenges that the procedure currently presents to healthcare professionals. So as Dr. Mani said, currently the landmark judgment on this issue is the Supreme Court judgment in Common Cause versus Union of India. This was a case that was decided by 5 judges of the Supreme Court in March 2018. Actually, even before this, in Aruna Shanbag's case, the Supreme Court had held that it was legally valid to withhold and withdraw life-sustaining treatment, but the court had some doubts about the legal foundations of that judgment, so it was referred to a larger bench. The larger bench heard that case and unanimously reached the conclusion that the right to die with dignity is a part of the fundamental right to life under Article 21 of the Constitution. Practically, this has one consequence for the purposes of withholding and withdrawing life-sustaining treatment, which is that there is a right to refuse life-saving treatment. So if a patient has healthcare decision-making capacity, is given all the information that is necessary to enable them to take an informed decision about whether to continue care or not, then that decision must be respected. Of course, doctors are duty bound to act in the best interests of their patients, and a process of shared decision making must be observed. But the overarching principle of autonomy and privacy and dignity is one that must be respected. So this is the crux of the Supreme Court decision, and I think it's important to keep this in mind when thinking about the procedure that the court laid down as well, because where there is a conflict between the normative principle and the procedure, I would argue, again, as a lawyer, that it is the principle that must be given respect to. So what is it that the court said in Common Cause? One, it said that it reconfirmed the fact that it was legally valid to withhold or withdraw life-sustaining treatment. And by that, it means that no criminal liability will attach to any healthcare professional who does withhold or withdraw life-sustaining treatment in an ethically responsible manner. Two, that advanced medical directives were now recognized as legally valid documents. Before this judgment, they were not. In fact, Law Commission reports in the past had specifically recommended that they not be recognized as legally valid documents, but this has changed with the judgment. And the third thing is that it's legally valid to withhold or withdraw life-sustaining treatment, even if there is someone who is not able to, does not have healthcare decision-making capacity and has not made an advanced medical directive. So even in an instance like this, it is perfectly valid to withhold or withdraw life-sustaining treatment. So these are the 3 primary effects of the court's decision. What also happened is that the court laid down a procedure to implement this kind of withholding and withdrawal, both when a patient has made an advanced medical directive and when a patient has not. And this is where the current problem with the practice of withholding and withdrawing lies, because this procedure is unworkable in a real life critical care setting. And unfortunately, the court has also said that its guidelines or the procedure that it's prescribed are supposed to be the law until Parliament or a state government makes a law to replace this. So it's important just to know, for your information, it's important to know what it is that this procedure currently says. I won't get into the specific details of it. For anyone who's interested, of course, I'm happy to share a copy of the judgment and point you to the relevant section. The basic crux of the procedure that the court lays down is that there is a three-step procedure before withholding or withdrawal can be effective. So one, the court says that every hospital should set up an internal hospital medical board that comprises certain kinds of experts, and these experts should reach a consensus that withholding or withdrawal is appropriate in that particular case. If they do reach that decision, then the case must be referred to an external board, which is to be constituted by the selector of that district, again comprising other medical experts, and the same kind of assessment and decision must be reached by that board. And the third one, and perhaps the most impractical of all, is that then a judicial magistrate, so this is a particular designation within the lower judiciary, this person must come to the hospital, confirm that everything is in order, there is no foul play, all the relevant procedures have been observed, and sign off on that withholding or withdrawal. So as you know, of course, this is, to the best of my knowledge, this is not a procedure that has been implemented by anyone. And it is not practical for this procedure to be implemented. And I think most importantly, actually waiting to implement this procedure goes against the fundamental principles that the court itself has laid down. So, doctors who refuse to withhold or withdraw life-sustaining treatment in this scenario because they are afraid of legal liability are actually not respecting a patient's wishes, are not acting in the patient's best interests, are not acting in the way in which medical practice dictates that they should act. So, I mean, I understand the dilemma for doctors who, they probably feel they're being pulled in two different directions, but this is where I think the law does actually have an answer. And as I said earlier in my talk, where there is a conflict between what the normative principle and the constitutional right requires you to do and what the procedure requires you to do, you must give effect to that constitutional right, and that right is the right to die with dignity. So what is, I mean, it's all very well for me to say this to you, but what does this mean in practice? So what should doctors do when they are faced with a scenario like this? So the first thing I wanted to say is that it's just important to bear in mind that one, of course, as I said, it's important to bear in mind that what you will actually be doing is giving effect to a constitutional right to die with dignity. The second is that it's important to bear in mind another legal principle, which is you must act in accordance with a body of responsible medical opinion. This is the standard that courts use when they decide whether doctors have acted responsibly or not, whether they have acted negligently or not. And at this point, at this juncture where India is today, there is a whole body of very responsible medical opinion that lays down detailed guidelines for withholding and withdrawal. So again, Dr. Rajani and Dr. Raj have already referred to all these guidelines in their talk. So the Blue Maple document, the FICCI guidelines, the AIMS guidelines, and the Indian Council of Medical Research's guidelines on not attempting resuscitation. Acting in accordance with these guidelines will protect doctors from any question of legal liability that might arise in an instance of withholding or withdrawal. And that's because these guidelines are actually far more detailed and provide far more safeguards than even the Supreme Court's and the procedure laid down by the Supreme Court as well. And the fundamental principles of these guidelines are that they are based on respecting patient autonomy, encouraging shared decision making, communicating clearly, documenting everything appropriately, referring conflicts to an end of life care committee or a clinical ethics committee within the hospital, and most importantly, deciding not to go ahead with withholding or withdrawal if there appears to be an intractable conflict. So again, practical legal advice from me would be that withholding or withdrawal should not be attempted when you have reached a deadlock, when you know that there is disagreement which cannot be resolved after multiple rounds of shared decision making. Then of course, in that instance, that's not an appropriate case to implement withholding or withdrawal. But in other instances, there is no reason not to. There is certainly no legal reason not to, especially when there is a detailed procedure that several responsible professional medical associations have laid down, including the Indian Council of Medical Research, which is obviously a public body in some sense. So this should really set doctors' minds at rest. I mean, I'm glad there isn't actually a case that I can point to. It's actually a good thing that I can't, that the court, that I don't have an example to give you of a case where this kind of action has been upheld by a court of law, because it shows that actually all the withholding or withdrawal that has happened so far has not been contentious, and there has been no litigation around it, and no one has been taken to court for something like this, at least since the court's judgment was passed in 2018. So it's a good thing that I don't have a legal precedent to give you at this point of time. So at the moment, my practical advice would be that, please refer to these guidelines, implement what you think is appropriate for the context in which you are practicing, maybe urge the institution that you are attached to develop an end-of-life care policy of its own, to take away, individual liability from doctors themselves. And yes, you will be acting then in the ethically responsible way, which is also the legally sound way. So I'll end there, and then as I said, I'm happy to answer any more specific questions that everyone might have. Thank you.
Thank you so much, Dr. Dhvani. We had a few questions in the chat, and I think Dr. Rajam and Dr. Raj were able to answer, but there is another question there. If the patient is in ventilator and we ventilator dependent and we withdraw support, patient will die straight away. So is this DNR or consent taken to not to intubate the gasping patient? So is this DNR?
If I may reply this, see, DNAR has a specific definition. We must not confuse all the terminology. In fact, the ICMR published a glossary of 25 terms associated with the ULC and detailed explanations. So DNR means do not resuscitate, decision, okay, prospectively. So it only pertains to CPR, okay. When you withdraw, it's called a withdrawal decision, and withdrawal decision is to take the life support and not to put it back. If you have to put it back, why are you taking it out anyway? So gasping patient, now you must control. That's where the palliative care component comes in. You have to give anticipatory palliation so that there's no distress in the patient, okay? And then those doses have to be titrated, obviously. So here, life sustenance is not the issue. It is the issue is to provide comfort and dignity in death and comfortable, peaceful end. So let us understand that whatever you do in the terms of withdrawal or withholding, the decision is made through the due process. You do not go back. Then what is the use of those decisions? Okay. You can sometimes go back in case this decision is reversed by the family, okay, for some reason, whatever reason. So, so only then, okay. And DNAR is also a part of withdrawal and withholding decisions. Once you've withdrawn a life support and the patient has a cardiac arrest, you don't go and do CPR. It is meaningless, because the premise for these decisions is that these interventions are of no use to the patient. They are doing more harm. They are delaying death, a natural death, isn't it? So you don't want to delay a natural death. That is the premise of these decisions.
Thank you, Dr. Raj. Dr. Dhvani, would you like to add something or?
Me?
Yeah. Just to.
Yeah, no. I agree with what Dr. Raj has said, and in fact, just to clarify the legal position on DNAR, this should be seen as separate from what the Supreme Court judgment has set out, because DNAR is a physician-initiated process and decision, whereas what the court's judgment is talking about is a patient-initiated one in some respect. So people should not feel confused about having to apply what the court's procedure to DNAR. The ICMR has laid down the procedure that should be observed for DNAR decision.
Yeah, I think there is another question. Is there a provision to bring in another expert if the family feel the interventions are indiscriminate and for monetary gains of the hospital?
Dr. Raj, would you like to take that?
Sir, you're muted.
Yeah. You see, now I was waiting for Rajani to take this one. Rajani is nowhere to be found.
Sure,
So,
I'm here, sir. I'm here.
Okay,
Sorry,
okay.
I'm on the
Now,
train.
now
So yeah.
the question is there a provision to bring? Of course, in medicine, it is absolutely ethical and professional and correct to allow any second or third opinions. Okay, it is not that we are obliged to adopt any second opinion, but there is whatever decisions are, they are subject to scrutiny by a third party, and we are obliged to answer any queries arising out of our decision. So that is, of course, that's a part of our medical practice in any way, even not just for end of life. It is for any decision, intervention decision also you take.
Absolutely.
The patient has every right to take a second opinion.
Yeah, I agree. Especially in situations like this, the patient and family has every right to request for another opinion. And one very important aspect here should be non-abandonment. When a patient or a family requests for another opinion, saying that an intervention that the treating hospital is offering is unnecessary, indiscriminate, for monetary gain, it's important that the patient should also be supported in the fact that if they call in another expert to opine on it, it doesn't mean, oh, you called somebody else, so now I'm no longer going to take care of you. We are ethically bound by professional that we continue to take care of the patient unless and until they say they want their care to be transferred over to another physician's care. So request for a second opinion, especially in life and death matters, still means that we owe our responsibility towards the patient. Non-abandonment is non-negotiable.
Very well said, Rajani. The non-abandonment is a very crucial principle. Okay, under all circumstances, non-abandonment. Now, one should not it is not professional to take offense or take umbrage because the second opinion it is a right. We have to respect, it's part of the autonomy. So if we have to practice ethically, we have to follow closely these principles and integrate them into our day-to-day practice, not just end of life. Okay.
So there is another question regarding, I think it's more regarding the infrastructure. Where do you actually shift the patient to another room where you have monitors and no alarms, or you keep there? So that's one question.
Of course, usually that's what we do. We move the patient, if it is feasible, then we move to a more, where there's more privacy. And it's true, you're not obliged to do all of end-of-life care in the ICU. You can do outside the ICU. And where visitation is free and more liberal, family can stay along. You don't have to monitor anything. Okay, putting a monitor there is just a counter, to what the foundation of the decision. Foundation decision to give peace, give dignity. So if there's noise all around, that's not good. In fact, it should be little spiritually, there should be a spiritual presence in the room, in the sense of whatever they want to be done in terms of ritual, or whosoever presence they want for this occur should be allowed. That is the full development of palliative care, right? And we should be available also as physicians. It's not that you leave them to their devices. You should be available for queries, for emotional support, for any nuancing of decisions in terms of symptom control. So, this is an ongoing way. It is the art and science of medicine combined.
Thank you, sir.
I'd like to address one more thing which just came up in my mind when this question came of move the patient to another room when there's a decision that there is palliative care or DNR. Another thing that comes up often is if a patient has had advanced care planning decisions done in the outpatient or in a prior hospitalization, and they have designated themselves as patients who would not want life-sustaining measures. And that patient comes back for a hospitalization in an acute emergency. One of the assumptions that's made is this is a patient with advanced cancer. This is a patient with an incurable, progressive, chronic end organ failure who does not want life-sustaining treatment. So therefore, that patient is not a candidate for ICU. That's a wrong assumption. We have to, at each admission, discuss with the patient what the goals of care are for that hospitalization. So the patient may be perfectly okay with receiving ICU care, maybe for a time-limited trial, as Dr. R.K. Mani pointed out, that the patient wants a time-limited trial of 48 hours in the ICU with NIV or HFNC, because they may have a goal that they're working towards. It might be that it is their daughter's graduation tomorrow, and they want to be okay for the next 24 to 48 hours. So just because the patient is designated DNR does not mean the patient does not qualify for ICU care. It should be quality ICU care with palliative care principles applied.
That was an excellent point, Dr. Rajani. Thank you for bringing it. Dr. Anish, you have a question? Please unmute yourself to ask the question.
Yes, myself, Dr. Anish, I am an intensivist basically. So my doubt is that there are situations when we have patients who want to get a second opinion, and we may not have a doctor in house, and they want to shift the patient to another hospital. And maybe the patient will be on NIV or HFNC. And another hospital, which will be a bit more high tech, and they will have a expert who can travel with the patient while transporting. And there are instances when the other hospitals have requested me to intubate the patient and transport, while the patient's relatives are not very keen on intubation. So basically that doctor is trying to keep the patient alive and safe during the transport without understanding the concept of palliative care, probably. But what we are trying to do is avoid unnecessary intervention. And this creates a lot of confusion in the patient's family, and that the other doctor has told to intubate. Why are you not intubating? So many times I have told them that it is not better not to intubate. If you want, we can get an online opinion. So these kind of things happen very often. So when such a confusion occurs, another doctor says you intubate and transport the patient, and then we are not very keen in intubating, then we will tell them that the result is going to be the same. What can we actually do in such a situation? Can we suggest not to intubate and transport on an NIV by taking the risk? And what if something happens to the patients while transporting? Many times that has also happened. While even shifting the patient to the ambulance, also patient had got into cardiac arrest. And if such things occur, a bad thing occurs during transport, will we be legally bound to answer that? So that is my query.
You see the question, see what you're saying basically is that our decision may be contrary to somebody else, the receiving physician, and there will be a moral dilemma. You see, the whole of this, we cannot reduce it to a simplistic problem of the law. medicine isn't simplistic. It is most of these decisions, in fact, end-of-life decision making requires a lot. It requires a lot of lateral thinking, a lot of clear thinking, and also communication. If the family clearly understands that the basis of why we are suggesting not to intubate or to withdraw, the basis of it is just this, that in our mind, to our mind, the prognosis is so poor that it doesn't justify burdening the patient. Now, if the family goes along with this view and we are able to arrive at a common decision, then it's fine. If the family is not going along with this decision, we need not, force it down their throat. Okay. And if they want to take a second opinion, they want to take the opinion of another person and implement it, let them do so. So I wouldn't come in the way of a family who was contacted another physician and he says intubate and bring the patient here, over here. It's their decision. I have expressed myself clearly why I won't give them the suggestion of intubation. It is for them to accept or to reject. It's the same as any interventional decision you take. I want to do an angiogram and the family doesn't want it. So I can't do it. Without a consent, I can't do anything, even if it is purportedly to the benefit of the family. And I may be very proud of my decision, but then that doesn't make it implementable unless it is accepted, consented. So if the family is consenting to your decision or you've taken a decision together, then fine, you implement it. If you cannot take a decision together, then don't take that decision. Yeah, let things be.
Yeah. The other, just from a legal perspective, you're not compelled to provide any treatment either that you think is not in the patient's best interest. So I think you perhaps have a duty to enable the appropriate transfer of that patient to other care and ensure that you act responsibly in that regard. But no one can demand treatment to be given, and you don't have a legal obligation to provide something that you don't think is appropriate. And again, that there's a clear line to that effect in the Supreme Court's judgment as well.
Thank you so much. And as Dr. Rajani has mentioned in the chat, documentation might be the key there, like to document whatever conversations that might have happened with the family, as well as what.
Excuse me, can I just say a little thing in this? Can the ICU doctor's concern was the other doctor having different opinion? Normally, whenever we do these type of things, the first communication has to be between the doctors, isn't it? So that rather than allowing, because before initiating any transfer like this, if the doctor to doctor communication is not there, we will not start any at all, because that is the first. Only when that is done, you can go, because that will save this person in the first place. So he need not have any query. The family, see, always family will have more of an emotional element. Professional element and integrity is very important. End of the day, this ICU person doing everything should not get offended or affected also in any way. So the doctor to doctor communication has to be the first level before anything is done. So that will save both the thing. That was just an opinion, I thought, which is normally done only in that way. So
yes, I would agree wholeheartedly, and that is the right way to do. One should project the impression of doing everything in the patient's best interest. So if you communicate with the other doctor, share opinions, and having shared opinions, frankly, you're able to arrive at a common decision very good. But it is that perfect situation may not occur all the time. In case that consensus is not there, then whichever opinion the family wants to follow, we should allow them to do so. As Dhvani said, we are not obliged to provide treatments which we don't believe in or we don't think are ethical. So we can always say, if I'm not able to do it, you can contact any other physician who is willing to go along with this intubation. Yeah, that's okay. That's being honest and upfront.
Yeah, I'd like to just give one small example from personal experience here too. It illustrates this problem. So we had a patient who had progressive fibrosing interstitial lung disease. According to the assessment at our center, this patient was not a transplanted. However, the patient's family, and this is real life situation, so they're never really perfect. The patient's family approached various different hospitals through connections and things, established that this patient is a candidate. Now, the lung transplant candidature has very simple, it's not something that one can fudge around. However, another hospital accepted this patient for lung transplant. Now, at this point, the family is asking for transfer of care. It may be that our decision of the entire panel of experts at our hospital was that this patient is not an ideal candidate for a lung transplant. However, another specialist in another made the decision, yes, they will go ahead and give a shot at lung transplant for this patient. At this point, we've had the doctor, we've had the conversation, we've had the documentation. Family's decision is to proceed with transplant, and the patient is then aided and transferred to the other center. Transplant. We did the conflict resolution, we had the conversations, we documented everything. No legal problems from us as long as we follow steps and document it.
I think, Dr. Rajani, we lost you in between, maybe due to the network. The last part was not really clear. We had a case presentation today, but I think the discussion is going on really well. I hope Dr. Shirley will forgive us if we skip that. I think most of the questions were answered. Whatever she has asked in the case presentation, most of the questions were answered during the discussion. Maybe we can take one more question during. We have 2 more minutes to finish. Dr. Shirley, I think if you have any questions, yes, please go ahead with those right now from your patient's story.
No, ma'am, no questions. It's answered. Thank you.
Anyone else would like to ask any questions before we wind up today's session? Or any comments, any thoughts?
If I get one, I just want to make one comment. Thank you, all of you, Dr. Raj, Dhvani, and Rajani. It's always a very much discussed topic. As you know, sir, whenever we have these kind of, especially ICU and palliative care, everybody is passionate about it, and there are always so many questions, which is really the best part of it. Again, coming back, just one point I would like to make and comment here is that when you see all these complicated end-of-life decisions, it becomes all the more important in your patients with chronic illnesses and general, patients who are elderly at home, and even those patients who are fairly healthy when they are following up with you. Please start talking about advanced care planning. The more you talk about it, the more plans and goals of care are in place, the less confusion at end of life. We really need to push into the culture and habit of talking of death and dying when the patient is well. We need to master the art well, discuss the options, let them take their time, but for that we need time with them. So all the more reason when these end of life care issues are always tricky, how much ever you have an inbuilt integrated palliative care in your hospital, you will have difficult situations. Therefore, when you're seeing a chronically ill patient or an elderly, or you have an elderly at home, or anybody who has diagnosed with an illness whose trajectory you know, please initiate the concept of living will. Talk to them of how they would like to die, document it, involve the family, and keep everything as clear as possible. There might still be a confusion, but at least hear the patient and document it. I think that's very, very important. I mean, I know Dr. Raj, Rajani, hands-on work with difficult ICU patients, and Dhvani has really supported us and educated me in the past 4 or 5 years. But I still think a difficult dialogue, which is done in a timely, unhurried manner, really helps you at this critical situation. So that's all I would like to add to this. It's even more important after this talk that we must talk about living wills and advanced care directives. Thank you.
Thank you so much, Rajan, for bringing up the advanced care planning into the picture again. We talk about it during every session from the beginning, but yeah. So thank you so much, everyone. Dr. Dhvani, Dr. Raj, and Dr. Rajani and Rajan. Thank you so much for being a part of this wonderful discussion. And thank you so much, all the participants. So we are at based